Hello friends, today I will teach you one important topic from immunopathology section of general pathology, that is the immunology of the transplant rejection. So I will teach you what is the pathogenesis behind the transplant rejection and what's the morphology because of that. Before I start my video, I request you to see the video in the high quality so that your quality of video will not get hampered. So let's start the discussion. Now before we understand that how rejection of particular transplanted tissue or graft will happen, you need to know which are the types of graft. So there are basically four types of graft: autograft, isograft, allograft and xenograft. These are the four type of graft. So first is the autograft. If the organ or the portion of tissue is transplanted from one part of the body to the other part of the body in the same individual, then it is known as autograft. Suppose the tissue from my leg is taken and that is transplanted over my face, then it is known as autograft. Now if the tissue grafting is done between the two twins or the clone, then it is known as isograft. Third type of graft, that is allograft. If the graft is taken from one individual and it is transferred or transplanted to the other individual of the same species, means between the two human, then it is known as allograft. So that is regarding the allograft. Suppose if Mr. X tissue is transplanted in the Mr. Y person, then it is known as allograft. What is xenograft? Fourth type. If the graft or transplantation is done between the different species, then it is the xenograft. So this is the four basic type of the graft. Now you might have questioned that why such transplant rejection is happening. So that is because the graft is recognized as a foreign by our immunity, so that our cell mediated and the antibody mediated immunological reaction will happen. Cell mediated and antibody mediated immunity will be activated, and that will lead to rejection of the transplant tissue. So that is the basic behind the transplant rejection. The graft is recognized as a foreign body. Now there is a three mechanism of the graft rejection. Such graft rejection is because of three mechanism. The first one is direct rejection. Second mechanism is the indirect rejection. And the third mechanism is hyperacute rejection. These three are the basic mechanism of the graft rejection. Now before I proceed further, you need to know that how CD4 T lymphocyte, CD8 T lymphocyte and B cells are getting activated when they are stimulated by antigen. So first of all, we will talk regarding the activation of the CD4 T lymphocyte, how they get activated. If you understand these mechanisms, then and then you can able to understand the graft rejection. So first of all, activation of CD4 T lymphocyte. Suppose there is an antigen in your body. This is the antigen. Now this antigen cannot be recognized by this CD4 lymphocyte directly. They cannot directly recognize this antigen. They can recognize this antigen only when macrophage or dendritic cell like antigen presenting cell presenting this antigen to the T lymphocyte. So the antigen can be recognized by CD4 lymphocytes only if they are presented by the antigen presenting cells. So they need to be presented to T lymphocyte. Now the CD4 T cell lymphocyte activation needs and one important molecule, that is MHC2. This T lymphocyte can recognize the antigen presenting cell only if this MHC2 molecule is present. Suppose I am giving you the example. I am taking your lecture through the YouTube. So I need an intermediate. So that intermediate is internet. Through the internet, I can take your lecture. So in this way, CD4 T lymphocyte can recognize antigen over the antigen presenting cell only if MHC2 molecule is present. So we can say that CD4 T lymphocyte is MHC class 2 molecule restricted. If class 2 molecule are present over antigen presenting cell, then and then antigen can be recognized. Now I will add more. Only this signaling is not enough. For full activation of CD4 T lymphocyte, there is a need to be activation of one co-stimulatory molecule, that is CD28. The corresponding receptor is CD28. So co-stimulatory molecule also need to be get activated. Now CD8 T lymphocyte, the mechanism is same, but it will utilize MHC class 1 molecule. So we can say that CD8 T lymphocyte is MHC class 1 restricted. So that is regarding the activation of T cell. Over the B cell, there is a presence of T cell receptor and it will recognize MHC class 2 molecule, and the co-stimulatory molecule is CD40. Now you can understand the mechanism of the rejection. So now we will move forward. So we will understand the first mechanism, that is the direct transplantation rejection. Now what happens in this condition? You are doing the transplantation so that graft is having the antigens and the antigen presenting cells like macrophage and dendritic cell. Our CD4 and CD8 T lymphocyte, means the host T lymphocyte, will directly recognize this MHC molecule of the transplanted tissue. This is known as direct transplantation rejection. It would be better understand in the figure. So we will see the schematic diagram of this direct pathway. So first I will tell you direct pathway activation by CD4 T lymphocytes. So just see here, this is the graft, antigen presenting cell of the graft. It will directly get recognized by CD4 T lymphocyte. It will directly recognize the antigen presenting cell of the graft. You already know that they are the class 2 restricted. So over the macrophage and dendritic cell, there is a presence of MHC class 2 molecule. It will get recognized. So what will happen? Now CD4 T lymphocytes can get proliferated once they recognize the antigen. So they will get proliferated. From 1 it will convert into 3, 4, 6, etc. They are proliferating. The proliferated T lymphocytes can produce one important mediator, that is interferon gamma. It can produce interferon gamma. Now this interferon gamma can mediate the delayed hypersensitivity reaction, type 4 hypersensitivity reaction, and it can lead to further damage. Additionally, this interferon gamma can stimulate the macrophage. It can stimulate the macrophages so that macrophage will get activated and they will release their granules to induce the further damage. So that is the direct pathway activation by the CD4 cell. Similarly, CD8 T lymphocyte also will directly recognize the antigen presenting cell of the graft, and so they will get proliferated, and CD8 T lymphocyte will get converted into cytotoxic lymphocytes. Now these cytotoxic T lymphocytes can lead to direct parenchymal cell damage. It can lead to parenchymal cell damage. And second thing, this cytotoxic T lymphocyte can lead to endothelial injury. So if your endothelium is getting damaged, then what will happen? Platelet coagulation system will be activated. So if the coagulation system is activated due to endothelial injury, there will be thrombosis. And because of thrombosis, there can be further ischemia, because it will reduces the blood supply through the blood vessel. So in this way, cytotoxic T lymphocytes and the CD4 T cell can lead to transplant rejection. So in short, we can say that MHC molecule of the graft will not be processed and it will be directly recognized by our host lymphocytes. That is known as direct transplantation rejection. Now I will teach you indirect rejection of the transplant. Okay. In the indirect pathway of rejection, the main cell is only CD4. Remember, in the direct CD4 and CD8 both will be involved. Here the main predominant cell is CD4 T cell proliferation. So how they will proliferate? You know that they will recognize the graft antigen through the help of antigen presenting cell. And now you have to remember that in the indirect pathway of rejection, our host CD4 lymphocyte will recognize the MHC molecule that is presented by our antigen presenting cell. Means the T lymphocytes get activated when they are presented by our own antigen presenting cell, not like that of graft antigen presenting cell. I will show you it in a figure, right? Here there is a presence of graft antigen. So now they will display to the host antigen presenting cell. So our host means host antigen presenting cell will display this antigen to our CD4 T lymphocyte. So we can say that MHC molecule get processed in the indirect pathway. Get processed in the indirect path means CD4 T lymphocyte directly cannot recognize the graft antigen presenting cell, but it will recognize antigen presenting cell of the host, means our body. So in that way CD4 T lymphocyte will activated indirectly. So they will activated once the MHC molecule get processed by the host antigen presenting cell. So that is known as indirect CD4 T cell activation. Now, once the CD4 T cell get activated, we have already discussed that it will get proliferated, it will produce the interferon gamma, and so it will lead to delayed type of hypersensitivity reaction and macrophage activation. That you already know. But additionally, here what happened? In addition to the direct pathway, here additionally B lymphocytes also get activated. How? Now you have to remember that in our body B cell is handicapped. Why I am telling that? Because B cell directly cannot activated. They can get activated usually when CD4 T lymphocyte stimulate the B cell. We can say that CD4 T cell will give the power to the B lymphocytes to get activated. So with the help of CD4 T lymphocytes, now B cell can get activated. And you already know that once the B cell get activated, it will get converted into plasma cell. That is a beautiful cell of our body. This plasma cell will lead to antibody production, and this antibody can lead to endothelial injury, further endothelial injury. So in that way, transplant rejection happen by the indirect pathway. Here the antibody production is also involved. Now I will teach you hyperacute rejection by the preformed antibody. Now sometimes what happen? You already have the preformed antibody against the graft antigen. So that is the mechanism in the hyperacute rejection. Now when you can have such preformed antibody, the examples are because of mismatch HLA in the previous pregnancy, because of previous blood transfusion, or the previously failed transplantation. In such condition, anti-HLA antibodies sometimes can already be formed. So that can be the responsible. So this is the mechanism how the hyperacute rejection will work. You are already having preformed antibody, and this is the graft antigen. So they will get combined. The antigen antibody will be cross-linked. So now what happened? There is a one cell in our body. The name is natural killer cell. The natural killer cell is a type of T lymphocyte that doesn't need the help of major histocompatibility complex. It is not MHC restricted. It can directly get stimulated. That's why they are the killer cells of our body. Now this natural killer cell having one receptor CD16 that will directly recognize the Fc receptor that is present over the antibody. So what will happen? There will be strong cross linking of antigen antibody and the complement will get activated. So complement system can get activated and they can lead to further damage. It is known as antibody dependent cell mediated cytotoxicity. So that is the pathogenesis of hyperacute rejection. So this is the three mechanism of the transplant rejection: clear, direct, indirect pathway, and the hyperacute rejection. Now I will teach you the morphology of the rejection. What will be the changes after the transplant rejection? So we can say that based on the morphology, we can divide the transplant rejection into the four types. First, hyperacute rejection, second, acute, and third one is chronic. Now again the acute is divided into cellular rejection and the acute humoral rejection. We will see each type one by one. So first of all, morphology of the hyperacute graft rejection. Now just remember the mechanism. In the hyperacute there will be pre-formed antibody. The antibody is already formed. So what will happen? The pre-formed antibody directly bind to the antigen and so the directly natural killer cell get activated and so the complement activation lead to damage. So the reaction will develop within minutes or hours, within few hours. The rejection will develop. Now what happened? Normally the fresh transplanted tissue is the red color and it will bleed. Usually it will freshly bleed. Here what happened? Because of rejection there will be thrombosis, there will be vascular injury, so there will be thrombosis, ischemia. So because of lack of blood supply the tissue will get cyanotic, it will blue colored and become flabby, that is called mottled appearance. So this is the gross changes, right? What you can see the microscopically, as it involves the arteries there will be pre-formed antibody and this antibody will particularly lead to endothelial injury, right? So what happened? There will be vasculitis and you can able to see the fibrinoid type of necrosis because of thrombosis. Because of endothelial injury there can be thrombosis and it can lead to ischemia, and so there can be finally inflammation and that can lead to fibrinoid necrosis. Because the reaction is rapid there will be neutrophilic infiltrate, there can be presence of fibrin platelet thrombus. So these are the three basic morphological findings. The main key feature is fibrinoid necrosis that can be asked in the MCQ. Now morphology of the acute cellular graft rejection. Acute rejection but cellular one. So the name itself suggests it will involve the cells, mainly cellular rejection is there. So it will develop within the few weeks to few months. And here the cellular rejection, so there will be presence of cells. Which cells can be present here? Just remember there will be T lymphocyte proliferation and so macrophage activation. So you can able to see the lymphocytes and the macrophage. Remember the mechanism of transplant rejection, cellular rejection. So there will be lymphocytes and macrophage and they will infiltrate in the tubule interstitial. So there will be tubulo-interstitial inflammation and the lymphocytes are either CD4 or CD8 lymphocytes. Here sometimes tubules can get damaged. This is the tubules of kidney, right? Sometimes it can get damaged. So there can be presence of focal tubular necrosis. Why it is important to identify such group? Because this group is best responsive to immunosuppressive therapy. Now morphology of acute humoral rejection. Here what happened? There will be newly formed antibody. The antibody is not pre-formed. If it is already present then it is hyperacute one. Here the newly synthesized antibody is responsible for the rejection through antigen dependent cell mediated cytotoxicity that we have already discussed. It is called as rejection vasculitis. Here the inflammation is classically present in the glomerulus and in the peritubular capillaries. It can be asked as a MCQ. So that is the morphology of acute humoral rejection. Now morphology in the chronic rejection. Now what happened? In the chronic rejection, the transplant rejection will develop after many months to year. After many months to year. And it is related to the indirect pathway of the rejection. Now remember, this rejection develop after many months. So obviously your inflammation will be subsided or it will get removed by the apoptosis. So there will be presence of only fibrosis. So predominant feature is interstitial fibrosis. Because of vascular change, you can show the intimal thickening as well. So there can be glomerular basement membrane thickening and the duplication, like that of, remember, membranous nephritis in the kidney chapter. Like in the nephrotic syndrome, there is a one type, membranous nephritis, membranous glomerulonephritis. So in that way, GBM duplication can occur. So that is the morphology of chronic rejection. Now you might have question how to prevent such transplant rejection. So obviously the best answer is you have to do the HLA matching, or we can say MHC matching. Why such matching is necessary? You already know the reason. Because the basic cell in the transplant rejection, basic molecule is the MHC molecule. So if we can match this MHC, it is called as an HLA matching, then problem can be solved. So the best preventive method is HLA matching. But if it is not possible, then you can give the immunosuppressant drug to lower down your immunity. One of the such cell is cyclosporine, that is commonly used. Cyclosporine. However, you have to remember that for the heart, lung, liver and the pancreas, HLA matching is not necessary. It is mainly needed for kidney, right? So in that way you can prevent the transplant rejection. Now these are some golden points that have been asked as an MCQs. Previously it has been asked, so remember that. Hyperacute graft rejection seen commonly in the kidney transplantation. Clear? If you have done the lung transplantation, then common cause of death is pneumonia, particularly by Pseudomonas organism. Now, third MCQ, that is very important. Which is the most common tumor after the transplantation? That is the squamous cell carcinoma of the skin. Second one is non-Hodgkin lymphoma, and third one is Kaposi sarcoma. These three tumors are related to transplantation. Now, which is the most common complication after hematopoietic stem cell transplantation? That is the immunodeficiency. So these are some golden points. Now we will see some MCQs for your entrance exam. In the acute humoral graft rejection, which complement deposit in the endothelium? So your answer will be CD4D. That you have to remember. The complement that is get deposited is CD4D. T cell recognize which type of MHC in the graft rejection? Now remember the mechanism. If you remember the mechanism, CD4 T lymphocyte recognize MHC class 2, while CD8 lymphocyte recognize MHC class 1. So the T cell can recognize both. CD4 and CD8 both can recognize simultaneously 2 and 1. So your answer will be MHC 1 and 2. 4-year-old lady received the kidney transplantation, and after 20 minutes tissue becomes cyanotic, and the histopathology saw neutrophils and the fibrinoid necrosis. Which is this type of rejection? Obviously your answer is hyperacute. Kidney transplantation done in 43-year-old male. After 2 years there was rejection of the kidney transplant. So which could be the possible mechanism in such rejection? Which could be the mechanism? So obviously your answer will be indirect pathway, because after 2 years there can be chronic rejection, right? And the chronic rejection is mediated by indirect pathway. Fifth, okay, so this is all about the MCQs, indirect pathway. Thank you very much. Hope my video will be beneficial to you in understanding the basic of the transplant rejection. If you like my video, then subscribe my channel and don't forget to press the bell icon so that you can get notified whenever I am posting the new video. So do subscribe my channel and kindly give the comments in the video section. You can write down the topic as well that you feel difficult to understand. I will make the video regarding that. Thank you very much.